Hi there. My name is Pam K Hayley, and I'm with Anthem. I want to thank Elizabeth, I don't know if she is still here, for sharing. Where is she? Okay, anyway, I want to thank her for sharing her story because, I think it really highlights why we're here today. It was incredibly touching, incredibly emotional, and I personally try to find something good that comes out of sadness and tragedy. You just try to find that one good thing, and Elizabeth has found something that out of her sadness, her tragedy, she's helped a number of people. And you think about the power of her book and the power of her story. So she's leaving a beautiful legacy behind in the name of her father and in terms of the work that she's doing. So so happy to be here and so happy to be part of the sponsorship of this program. I think that for those of you that kind of can think this through, the thought of an insurance company being part of an event like this, it's a little bit sensitive. And so there was a little bit of nervousness about us having our name tied to this and me actually standing up here talking. But I think it's very important that the insurance industry is a part of this because we can be a platform for positive change. We can be a vehicle for positive change. And I think, being here is a, just as testament to that. So there's a lot of statistics I have on these cards here that talk about how what people want at the end of life is just not happening. And I'm not going to go through them because we heard about them this morning. But the sad fact is that the way that people want to end their life is not the way it's happening now. And, the fact that we're here today having this conversation is I think, huge progress from being tarred and feathered 10 years ago. I mean, who would have thought 10 years ago that we could be all sitting here having a conversation about something so sensitive, something so emotional, but something that's so important. So I want to thank the Leonard and the Schaefer Policy Center for USC Schaefer Policy Center for creating this platform to have this very important discussion. I think that we need to continue to have these discussions and continue to make progress. So how can insurance companies help in this particular situation? I'm going to share with you one of the programs that we have. It might not be the best thing. It might not be the answer. But my point is that, again, this is a situation where a lot of different stakeholders working together can really affect positive change. So we have a number of programs that we're pursuing. One of them that we have implemented is a telephonic care management program. And we partner with a company called Vital Decisions. I'm not sure if any of you have heard of that company. But what they do on our behalf is we identify individuals that are at a point in time where an end-of-life situation is nearing. And we provide that information to this vendor, and they reach out in the form of a letter and a phone call, and they offer their services. They offer support to help them make decisions about their end of life. And the member that's received this reach out can either opt to participate in the program or not. They don't have to. It's their decision. We simply put the resource out there for them to decide. If they do decide they want to participate in the program, an expert, a counselor, will reach out to them and have a discussion with them, a very candid, open, honest discussion about how their experience in end of life, how they want it to be. They ask the questions: do you want to die at home? Do you want to die in the hospital? What do you want to do? So the right questions. The other thing that this interaction, this counselor helps them do is how to communicate what they want to do to the right people. So this is such a difficult conversation. How do you have this conversation with your family? How do you tell your friends what you want to do? How do you make sure that all the clinicians, the doctors, know what you want to do? How do you do all that? So this counselor does help with that situation. So just a service, a way that an insurance company can help. And this program is not unique to Anthem. Other insurance companies are trying to figure out ways to help in this space, because it's just a very, very important, an important thing to really fix, because it's just not working now. So with that, I'm not going to stand up here and speak. I'm going to introduce the next speaker, and I'm happy to do so. The person I'm going to introduce is Claudia Crist, and I actually met her this morning, and she said, just pick out the good things out of my bio and talk about those. And I looked, and they're all really good things. She's got an impressive background, so I'm going to go through the whole thing. So Claudia is the Chief Deputy Director of Policy and Programs for the California Department of Public Health. Claudia has also served as Deputy Director of Healthcare Delivery Systems at the California Department of Healthcare Services. And from 2000 to 2014, she held various administrative posts at Sutter Health. Additionally, Claudia was a lecturer on multicultural health and healthcare delivery systems at the California State University of Chico from 2013 to 2014. Earlier in her career, Claudia worked as a hospital-based charge nurse, staff nurse, and laboratory assistant. She is also a member of the American College of Healthcare Executives and the California Association of Healthcare Leaders. She was voted Woman of the Year in 2011 for the Greater Sacramento chapter of the Leukemia and Lymphoma Society. In addition to undergraduate degrees in healthcare administration and nursing, Claudia holds a Master of Health Administration degree from the University of Southern California, Sol Price School of Public Policy. So please join me in welcoming Claudia.
I was told the first thing you do is adjust the mic. How is the mic? Good? Hello, everybody. Well, I have to tell you, I am quite intimidated to speak to this group for a couple of reasons. One, you're all experts at what you do, and I get to talk more in generalities. And I hope I'll bring something to it that I think you're maybe a little bit less familiar with, so I look forward to that. Secondly, I graduated from USC, and they're right here. And they're probably still writing reports about me. And so I hope that I hope it goes well, because if it doesn't, it really reflects poorly on this whole event. And then thirdly, I wanted to also acknowledge Peggy and Cedars-Sinai. And Peggy and her team came to talk to me a while back about an issue that we needed to work together on with one of my hats, licensing and certification. And she's great. And I told her, oh, Cedars-Sinai. I said, that was the first job I applied to straight out of nursing school. And she says, oh, great, what happened? I said, I didn't get the job. Good thing is they have me come back, so it's all good, no worries. There's I hold no grudge whatsoever. And you wouldn't want me today. I've been out of the field for a while. So I'm absolutely proud to be here and humbled to be here, really more than anything. And while I'm here as a representative of the state of California, I'm also here, I think, really first and foremost as someone who spent a big part of her career as somebody that provided direct patient care in ICUs, in ERs, in various rural and urban care settings, and also as a hospital and healthcare administrator who had to deal with a lot of the things that were brought up today. And most importantly, I feel I stand before you as a daughter, a sister, and really just a human being who believes that everyone should have the opportunity to spend their last days in the setting of their choice, whether that be at home or somewhere else. So with that, and before I go into my material, I did want to reflect upon a couple of things that were shared today that I thought really stood out. Everything stood out so far. Somebody said, what people want versus what actually happens. This was said a couple of times. This is a concern of ours. I also found it very poignant when one of the physicians here in the room, I'm not pointing, said, we are trained that we're failures if we don't solve the problem in front of us. And I certainly found that as both a great thing and a barrier when I was in charge of a cancer center and quaternary care and a bone marrow transplant unit, when I was encountering exactly that. I was encountering specialists that believed that very much, and that meant that palliative care was not allowed to enter the room until the minute before the patient died, as well as the cancer expert and, their colleague who was in a much different place with this. So I very much respect and understand what's going on there. I also heard more isn't necessarily better. Better is better. Earlier might be better. And another big thing that I heard today is, why don't we know how we're doing? We don't really know exactly how we're doing. And that was reflected a lot in our answers today as well. And it would really be great to know how we're doing so that we can do better. Have to start from somewhere. And of course, up until this very last presentation by Elizabeth Bailey, the perspectives of what she went through and her family went through and what her father went through, her father's story, Lewis. And I work for public health, and I'm not allowed to advocate for drinking. But I have to tell you, if for some reason any of you in the room do indulge here and there in gin martinis, I think tonight is a good night to raise your glass to this gentleman named Lewis and say hi. And so what I took away from Elizabeth were many things, but one thing that also stuck out was modern care, healthcare, makes it hard to trust your human intuition and sense and instincts. So with that, I'm not going to repeat a lot of any of the statistics really that were mentioned already. But earlier today we heard about what Californians prefer, and we know what the majority of us prefer to spend the last days of our lives at home. And there was also a national study, I think it was 86% or something, where that number was brought up as well. And then there was the reality that we talked about today of, yes, but this may be something that people want, but it is really hard for their families to make that happen sometimes. So acknowledging that as well, right? It just adds to the hurdle. This map was recently published in the New England Journal of Medicine in October of this year. And it gives us an idea, just looking again, and this is data limitations, right? This is just Medicare data, but still gives an idea of how we're doing as a nation and by state in spending the last 6 months of life at home. If you have a hard time reading the legend, lighter is better. It is Medicare data. It is sorted by, you're wondering, like, what is this, counties? What are we talking about? This is by hospice referral region. And this is based on people that passed away in 2012 and 2013. The article is called Days Spent at Home, a Patient-Centered Goal and Outcome, where they also talk about 86% preferring to die at home, based on a 2007 study as well. I should go back, but I should go back briefly. So, as you look at California, there are several gray slots, and it just means that there wasn't enough data elements to provide a valid statistic. But for all the other areas, what do you think how we're doing in California? Kind of a little bit all over the place? Do you notice any trends? I'm not pointing fingers, I'm truly asking. No, I'm truly asking. Well, listen, I am from Northern California, but the reality is we have a third of the population living right here. So I'm not pointing any fingers. I'm just saying don't point and say it's bad here, it's good here. It's just, it could be based on a lot of different factors, right? But it's just the reality of how it kind of is happening now. That's my point. And then you can take a look at the rest of the nation. No finger pointing. In our Center for Healthcare Statistics, one of the things that we get to track here at Public Health is birth and death records as well. And in looking at the 2010 group of death records, sorted by several race and ethnic groups, but certainly not subcategorized as it appropriately should be. So I apologize for the lumping. I want to acknowledge it right off the bat. And I also don't have in here people that listed 2 or more races as as there. So, but just kind of looking at some of the major buckets, if you will, it is important to note kind of what the top 1, 2, 3, 4, and 5th cause of death are listed on the death certificate right now. And it's also important to note that for the first time, I think, and doctors, you have to correct me, I'm just a nurse, but I believe cancer has actually surpassed heart disease as the #1 cause of death here in California. So as you look at those causes, how does that match with what you're seeing in your daily work with the patients and the residents that you are interacting with and the families? Is that a pretty sound about right? I can only go off of what's on the death certificate, so it's only as good as what's on there, but just so we know another aspect of our patients. So now I understand that this afternoon's breakout groups is where really a lot of the heavy lifting is going to get done, and I'm very excited about a lot of the topics that you will be tackling. Unfortunately, I won't be able to be there for this part. I was invited, just so you know. They didn't say you can't be there, but I have to fly back. So many of your experts in palliative care, hospice, advanced care planning, advocates, chaplains, social workers. So I thought I'd share with you a little bit about Let's Get Healthy California as it relates to end of life, and just to maybe give you a little bit of an introduction in general. Who in the audience is actually familiar with Let's Get Healthy California? Okay. So this is typically, so not as many, and this is typically what I find when I talk to people in healthcare. And with me coming from healthcare and having just been transplanted into the wonderful world of public health, I thought this is my opportunity to help create that bridge. Because I think Let's Get Healthy California, which is, by the way, our official state health improvement plan for the state of California. So you should take a look at it. There are great opportunities that we have, and the goal is to make California the healthiest state in the nation in the next 10 years. So almost 4 years ago, the Let's Get Healthy Task Force was assembled to look at all things Californians might do to become the healthiest state in the nation. And of course, looking into that, it was by advancing the triple aim, promoting health equity, and reducing health disparities. Another amazing thing that I get to do now as I work in public health is really focus on health equity and disparities as well. So the guiding principles that were used is, what will it look like if California is the healthiest state in the nation? And what will it take for California to be the healthiest state in the nation? How do you even measure that? So the triple aim, as I mentioned, better care, better health, and lower cost, was used as a foundation to guide the process in developing strategies, goals, and indicators. And then national and state reports informed and enhanced the development of the goals and overarching framework. So they embarked upon this work almost 4 years ago now, and a report was then issued. So this task force identified a total of 30 priorities within 6 goals. And this is where you can see how end of life is right on top there. So a dashboard was developed with 39 measurable indicators that, taken together, they say, convey the state of California's health at both the population and the system level. And there were also, I think, another additional 9 indicators identified that don't yet have a data source behind them. The report was issued in 2012, and among the top priorities was end of life. Furthermore, this particular framework makes it clear that health equity should be fully integrated across the entire effort. Health outcomes vary dramatically by demographic, geographic, and a host of socioeconomic conditions. For California to be the healthiest state in the nation, health disparities must be reduced and ultimately eliminated. No small feat. The underlying principle guiding the establishment of this 10-year target is that these gaps can be closed. one of my colleagues at the California Department of Public Health is Jamal Miller, and he's the deputy in charge of the Office of Health Equity that was created just a few years ago by legislation. It lives in the California Department of Public Health, but it is really for the state as a whole. And so there is a product that was generated. Again, this is not by state people. This is by huge groups of stakeholders. That's called the Portrait of Promise. Have you read? So you don't have to raise your hand. But if you haven't read the Portrait of Promise, this was the baseline assessment of how we're doing in health equity in the state of California, and talking about what we can do to help it. So this, as healthcare people, you have an important part in this as well, but it really starts very, very, very far upstream. But as members of the healthcare community, this is something important because there's no better time through the ACA and many, many other policy decisions that have been made at the national level, really for public health, healthcare, and the communities to come together to make this the healthiest state in the nation. The time is now. It's super exciting for somebody like me that has spent 25 years in healthcare in California and before that in Germany, to be in public health and to bring us together. So that's my personal mission, which I'm not allowed to disclose. So, oops. No, they didn't say I couldn't. And who is they, anyways? Tying it all together. So these are the 6 goal areas. So healthy beginnings. End of life starts with the beginning of life, and the experiences that we have in the first 5 years of our life to start with. It goes on to living well. Managing chronic diseases through the life journey can certainly improve the quality of end-of-life experiences. And then there is the end-of-life goal category itself. So end-of-life is not just that red box. It really kind of could be addressed in any of those areas as well. And a good example of that in the living well category, so I'm going to bring up some things. If you know them, tell me to just move on the slide. But the AARP produced the livability index. Have you seen the livability index? Yes? Some people know. Can you raise your hand if you've seen it? Yeah. Okay, good, good. I just need to gauge whether I'm sharing things with you that you already know, because I don't want to. You are experts. But what I really like about this, it's a web-based tool that uses 7 categories, including housing, transportation, neighborhood, environment, economic opportunity, health, and civil and social engagement to measure the health of a community. So of course, naturally, I put my zip code in where I live. I came up with a whopping 50 out of 100. But during this, I want you to put in the zip code for here right now, just for fun. And then for where you live, just play a little bit. We can multitask. We're super talented people. I thought it was great. And then you can break it out into subcategories of that to really understand. And you can even say, hey, this part isn't as important to me as I consider a community or as I'm an advocate for a community. This part is more important. So you can move the dials on each of the subcategories. It's quite amazing. The other part is the, I think I wanted to talk about health homes. So under the living well categories, I would also put health homes. And this is the Medicaid health home state plan option, which is authorized under the Affordable Care Act, Section 2703, that allows states to create Medicaid health homes and provide supplemental services that coordinate a full range of physical, behavioral, and behavioral health and community-based long-term services for Medicaid beneficiaries that qualify. I understand in talking to my colleagues at the Department of Healthcare Services that on October 21st, the Department of Healthcare Services received approval from CMS on the revised attachment for I'm going to talk about the whole person care pilots next. So whole person care pilots, also under the Medicaid 1115 waiver, is something they're working on, and that really allows the coordination again of health, behavioral health, and social services through a more efficient and effective use of resources. It allows, these pilots would allow then an option for a county or a city and county or a health and hospital authority or a consortium of any of the above entities serving a county or region to receive support to integrate care for particularly vulnerable Medi-Cal beneficiaries who have been identified as high users of multiple systems and continue to have poor health outcomes. I would venture to say that all of these things, if we can make these happen, help with a little bit more of the upstream part of the very end of life. I need to see what you're seeing right now. Oh, I see it right here. Look at that. Linkages. So one of my staff members put this on there. I'm not favoring Sutter Health, but the Drucker Center for Health Systems Innovation came up with linkages, and it's a virtual bank of volunteer hours for a community. The intent is for an able-bodied person to offer volunteer support to an elderly person to help them stay in their home and relieve family caregiving responsibilities. The volunteer, in turn, then can cash in their hours for service of use to them, for services of use to them, such as tutoring, home maintenance. And so this network seeks to address some of the isolation issues experienced by many seniors. And I realize the people that are dying in California aren't just seniors, but this is just one other example of something that's happening in the communities, much more upstream, that I thought was remarkable. One of the Let's Get Healthy Innovation Challenge finalists last year was Building Healthy Communities South Kern's Live the Challenge program. Live the Challenge is a 100-day challenge asking South Kern residents to commit to making one healthy change, joining with other residents, youth, businesses, and organization agencies to establish new and healthy habits. And it was quite successful. So this community is making a healthy difference in people's lives from young to old. Again, you are dealing a lot with the very end of the end-of-life issues. I'm adding the public health aspect and the piece that can really help make a difference in the upstream part of that. Because it then will tie in and make your life easier, hopefully, as well. So when you look at the end-of-life goal, they selected several indicators that are supposed to tell us how well we're doing. I don't know how exactly those were chosen. I wasn't there. It might have been that this is what we decided gives us a good indication of how well we're doing with end of life. Could also be a combination of this is something we can actually measure. But you can see access to hospital-based palliative care being one of them, increasing the use of hospice care, terminal hospital stays that include ICU days, and advanced care planning. And I know Judy Thomas from the Compassionate Care Coalition is going to host a breakout group today where you're going to tackle that topic as well. And there's been so many advances and so many great innovations on that topic already, but we have so much further to go. So I'm glad you're working on this. The New England Journal of Medicine article that I referenced earlier, and I just read it again not too long ago, it actually claims kind of a negative correlation between the number of hospice and home health services and days spent at home. What we thought was that the earlier and the more hospice and home health interventions we have, the less likely people are going to be admitted or having not stays at home. And so they had looked at they looked at focus groups that were conducted by the Camden Clinical Commissioning Group in the UK, and then they also took that and did a deeper analysis of Medicare data for days at home, and that's what they found. So what their point was, though, is it's not just about the quantity, right? It's about the quality of that service. Not saying that it shouldn't happen, saying it should happen, but also looking at how does it happen and what does it consist of. So end of life. The clinical health domain focuses on a diagnosis and treatment of an individual facing the end of life. The public health domain works on preventing populations of people from experiencing what we call a bad death. Death, then, is unpredictable and can happen at any time during the course of a person's life journey. It occurs within all life stages, infancy through late adulthood. And it may certainly occur suddenly or be an ongoing condition. And end of life is about quality. which we've heard a lot today about, or about today, if I use the correct grammar. This is German grammar. And then lastly, end of life is a community issue. The stresses of navigating end-of-life care often reaches beyond the patient, creating a ripple effect, negative outcomes into the dying person's family, friends, care providers, and even community. So I'm not trying to expand the problem you're already thinking about. I apologize. But I want us to think also a little bit even further upstream and have the public health world and the community world come in a little bit more. You play a critical part in this. So how are we doing on these Let's Get Healthy indicators? So the baseline used was 2012 data. So the first indicator, increasing access to hospital-based palliative care. The most current data we have is 2014 data. So the center that you see, the percentage, 51.9, is 2014 data. So end of life is certainly one of the most difficult stages of life and is in need of attention and improved care. One of the things that I want to go back to is data. We have to know how we're doing, and it would be really nice to know how we're doing more concurrently. A lot of people are answering, don't know yet because of the data lag, which is an issue that is critical, especially when you deal with issues in public health and healthcare. I can tell you that one of the centers I get to work with in my role is our Centers for Infectious Diseases, and you don't want us to have a data lag when we're working with you on those things. And that works pretty well. But it would be really nice to be able to have more concurrent access to data. So maybe that's something to think about. Who has a role in that? How can we make that happen? Because that needs to inform our interventions and our policy decisions as well. Increasing the use of hospice care. What does it say on your screen right now? It says, I'm so behind by a whole slide. Okay. So here's how we're doing on increasing the use of hospice care. California target. What do you think about the California target? The definition isn't clear. And I know it's defined somewhere, but I still say the definition isn't that clear. But Californians use hospice less than the rest of the nation. Tracking hospice enrollment rate is nice, and it helps to measure not only the rate of use, but we also need to measure the duration. And then reducing terminal hospice stays that include ICU days. I can't tell you how many times, and many of you have been in the same spot, that I've been caught in the middle of family fights about what should happen to the loved one that was in a coma or on a ventilator and just was clearly, you know, there might have, and there was even, let's say, a will, and you had it all there, you had an advanced care directive, but it was really hard to act on it because of everything else that was going on. So you're all there. I know this. I can, you know, but I'm just acknowledging that having that talk, teaching people how to have that talk with their family early, not just having the document. I'm going to ask you about your document later on, but having that conversation early. This is a slide I'm going to jump over fairly quickly, but just to give you an idea of deaths in hospice by race, and then a juxtaposition of the total population of California. I want to acknowledge that most of the people that die are older, and most of the people that are white are older, so it's not necessarily telling you that there's a huge issue, but it's certainly something to take a look at, and it does tell you who is in the pipeline as you are thinking about the models that you're creating from a health equity and from a cultural competence perspective as well. So advanced care planning. You're going to talk a lot about today, but in an article that our Health and Human Services Secretary Diana Dooley published last fall titled Living Well, Dying Well, I thought she did an amazing job of sharing personal stories between both her own family and her husband's family and how different the experiences at end of life were. In a 2011 survey commissioned by the California Healthcare Foundation, nearly 80% of Californians said they would probably or definitely want to talk with their doctor if they were seriously ill. Yet, only 7% said their doctor ever raised the topic, and only 23% said they had written down their wishes. So you have this data. This is these are our friends in the room that are providing this data and putting this all together. Our Coalition for Compassionate Care as well, and also the California Healthcare Foundation. The two of them, I think, provide us with most of the data that we have and use, but I have to tell you that this is certainly interesting in looking at what are some of the things to consider as we're working on this, and also barriers. As we look at legislation, I was asked to just provide very high level kind of what's going on. As you all know, the End-of-Life Options Act was passed and allows adults diagnosed with a terminal disease who meet certain qualifications to request a prescription for an aid in dying drug from their physician. So this puts us on the map as one of 4 states in the United States that have an end-of-life option legislation. The light-colored states are states that are considering it in this next year's session. And the states that are darker colored don't have any activity as it looks at legislation at this point. So the other states are Oregon, Washington State, and Vermont that have it. You all are familiar with SB 1004, palliative care. Do I need to talk about that? But I just liked this care model that was shared with me by Anastasia Dotson from Department of Healthcare Services, which outlines this care model that was actually adopted from the National Consensus Project for Qualitative Palliative Care. I should probably say one more thing on this, though. So the early palliative care part on the very left of the slide is often kind of advanced care planning, palliative care consultation, includes pain, symptom management. And then the wavy line indicates the proportion of palliative care and disease-modifying curative care varies based on individual patient choices and needs. But then the SB 1004 palliative care piece is shown in the segment where then it applies kind of in this section where the patient's illness progresses. Those with serious illness who meets specific clinical criteria can then enroll in palliative care program through SB 1004 on the Medicaid side. And then those that meet hospice eligibility criteria, they can then enroll in either hospice or palliative care. I think we're all familiar with palliative care services. Medi-Cal shows us that the conditions that are highlighted or also in yellow, they're conditions for which SB 1004 potentially applies as well. And this shows you the Medi-Cal data, most frequent deaths from Medi-Cal folks in 2013. This also shows you inpatient utilization and ER utilization in the last 6 months of life, or last 18 months of life, and as we go towards the last 6 months of life, the utilization for both inpatient and ER going up still. I'm going to skip this. You can all read about Dr. Carl Sternberg and his palliative care pooches. I just wanted to lighten the mood a little bit. I also used to run a pet therapy program, so I'm a little partial. So pulling it all together, collectively, we can certainly have an impact. There's, as I said, no better time for healthcare, public health, and the communities to come together to help ensure that the quality of end of life is enhanced. What if we shifted away from the approach of end of life from diagnosis and treatment of individuals to preventing populations of people from experiencing a low quality at the end of life? Or improved overall end of life outcomes by addressing the social determinants that cause a low quality end of life? or build a collective impact around end-of-life priorities that address all aspects of end-of-life, including physical, mental, emotional, and social. So my message to you is, I can't wait to work together with you on this. Let's Get Healthy California had several innovation challenges. Had an innovation challenge, and there were several finalists in the end-of-life category. By the way, the next series of challenges was issued, and we should be finding out in December who is the finalist. And we know that there were 10 submissions or so that we got for this round, roughly 10 submissions, I was told. So it'll be interesting to see. But the ones that we got for last year that were finalists were the Medical Legal Partnership for Seniors, University of California, San Francisco, and also University of California Hastings Consortium of Law. This is where UC Hastings students develop key lawyering skills through representing low-income older adult patients, and they have to do what they call a whole wraparound whole person lawyering. So they really get to have a connection with these folks and get to really understand the whole picture as it relates to a person as they approach end of life. prepareforyourcare.org. Last night I had dinner with an elderly couple here who are my friends, who are in their 70s, who told me they don't have an advanced care plan. Guess what how that conversation went? And then UCLA, as another example, Health Coalition for Compassionate Care of California Advanced Care Planning Initiative is also one that was highlighted. So the Coalition for Compassionate Care partnering with UCLA to develop and test an innovative comprehensive advanced care planning model. But I'll let Judy take that later on. So I'm finishing with 2 challenges to you, and I'm sure you'll have plenty for me. Well, 3 challenges. The first one was to raise your glass to Louis Davenport Bailey. The second one is to start the conversation. I know that those of you in the room specialize in starting the conversation, but maybe you can figure out how to help your colleagues in starting that conversation. Ms. Bailey talked about the fragmentation of care and the specialists and how it seemed like nobody was thinking about being the owner of that conversation. So how can you, as those that are already doing it, help your colleagues? And here's the last one for you. You work so hard to take care of others. Make sure to take care of you. Have you done your own care planning, advanced care planning? Thank you very much. Do I jump off the stage? I can totally just jump off the stage. It's all good.
In the interest of time.
Yes.
Yeah, we'll have more discussion during the lunch hour.
Perfect. Can you promise me that you'll fix it all? And then the Judy and the team and USC, they can send us what you came up with and we can help implement. Thank you very much.